Hello and welcome everybody. Welcome to CORTH. My name is Maya Onithan and I'm a medical anthropologist based at the School of Global Studies at the University of Sussex. On behalf of my fellow co-directors, in the schools of medicine, Chiesi Fuela, in the School of Law, Maria Moscati, in the School of Development, Haley McGregor, and myself in Global Studies. I welcome you heartily to this CORTH Research Center conversation. This is an event where we have experts in the field of public health, medicine, policy, and kind of cross-disciplinary range of academics come and talk to us, discuss, and reflect on current topics in the kind of broader and intersecting fields of sexual and reproductive health. So I'm just going to briefly introduce our speakers and chair for today. I'd like you, if while I'm doing that, to also perhaps populate the chat box, say hello, and send us your affiliations, where you're joining from. That would be great. So it gives me great pleasure to welcome our speakers for today. So Dr. Sue Mann is the National Clinical Advisor in Reproductive Health at the Department of Health and Social Care, and also works at Homerton Hospital as a consultant in women's health. She has joint accreditation in clinical and public health practice and has had a long-standing interest in the grounding of women's reproductive health from a population and public health perspective. Sue has actually not only helped shape, but actually lead the sort of policy direction of reproductive health here in the UK, and has both published and spoken widely on this topic. Along with Sue today, we have Dr. Lydia Leon, who is a program manager in reproductive health at the Office for Health Improvement and Disparities. Lydia has a PhD in child health and is interested in health inequalities in access to contraception and women's health care. Joining them is Dr. Lucy Porter, who is a behavioral insights advisor at the Office for Health Improvement and Disparities. Lucy has a PhD in psychology, and her main research interests are eating behavior and sexual and reproductive health. So a very warm welcome to you. It is a, as I was saying earlier to Sue, Lydia, and Lucy, it's wonderful to have people directly within the context of making policy and in the where the action takes place to come and talk to us about what's happening. So having this direct connection. We are also really fortunate that our Professor Keith Jones, who is actually the Pro Vice Chancellor for Research at Sussex University, will be chairing the event. Keith is an expert in the field of reproductive biology. His personal research is in the study of how oocytes grow into mature eggs and the process by which fertilization is triggered. He has been editor-in-chief of the journal Molecular Human Reproduction and has contributed over 60 research articles, 20 reviews, and 5 book chapters to this field. In the UK, Keith has received funding from many research councils, including the BBSRC, the MRC, the Wellcome Trust, Leverhulme Trust, and while in Australia from the ARC and the NHMRC. Professor Jones has been a member of the BBRC Genes Development and STEM Approaches to the Biology Committee, as well as the ARC's College of Experts. He holds an honorary professorship from the Chinese Academies of Sciences Institute of Zoology in recognition of his contributions to the field of reproductive biology. So we are really, on behalf of the members of CORTH, I invite you, Professor Jones, to chair the session and to facilitate the discussion and questions to do with, the reproductive health tools, and what are the new tools and the new insights in the UK. Thanks very much.
Thanks, Mayor, and good afternoon, everybody. It's an absolute pleasure to chair the presentations that we've got this afternoon, and a particular delight because reproductive health and reproductive biology are areas that I've taken an interest in, as May's described, over the past 25 years. So I'm really looking forward to the presentations this afternoon. Just by way of the format, I understand Sue, Lucy and Lydia are going to spend about 40 or so minutes with their presentations. And what we'll do, if that's okay with the speakers, is we'll delay any questions until the very end, and then I'll open the floor. So please hold back on those questions, and we'll take questions at the very end. So I'll sort of pass immediately on if everybody's okay to Sue. Thanks, Sue.
So thanks so much, Keith, and thank you for that introduction. And likewise, it's a real pleasure to be here. So I'm really excited to have discussions with your group. I think we obviously have some very common interests, and I am really committed and motivated to try and improve the way that policy making and research interface and come together. And I think it's a long-standing forever problem, but the more that we can do to try and foster these connections, I think the more difference that will begin to make. So what we thought we'd do would be to just set a little bit of context about what we've been doing in Public Health England and what we now hope to continue to do in the Office for Health Improvement and Disparities, but it's all a moving field at the moment, so very new to us. So we're going to present this work that we did as part of Public Health England. And really what I want to do is sort of think about the journey that we've taken in that. So when I first came into post, which was 2016, I'd come from a background that was around an academic perspective in terms of knowledge mobilization. So I'd just come out of a NIHR fellowship in knowledge mobilization. I came from a sort of clinical and public health perspective on reproductive health. And I came to Public Health England, which was the arm's length body for England, which was the sort of evidence body to inform policy making. So at that time, it was separate from the Department of Health, and it's now been integrated, but still holds some of the very similar functions. So came into the department, which was sexual health, reproductive health and HIV. And at that time, reproductive health was really focused around contraception and really in terms of policy, and very much focused around the delivery models which we've had most recently, which is around delivery of contraception within a sort of sexual health setting. So it acknowledges the bit of reproductive health that is about that links with sexual health, but less the broader parts and less the sort of public health elements. So starting from that point, we decided to start investigating and taking a perspective that was much more sort of population-based and had a greater breadth in terms of its approach. So I'm going to tell you a little bit about that journey, and then I'm going to hand on to Lucy and Lydia, who are going to talk more about some of the work that's come out of that initial kind of baseline, really a baseline needs assessment, which is what I'm going to talk about. So Lydia, I'm going to ask you to move on the slides, if that's okay. So this is not this is a definition of reproductive health that is very much out in the sphere. I think it's one that we all understand, probably the most comprehensive one that we can find, although there are a number of different ones. And I think we do have a problem with terminology in terms of reproductive health. Do we call it sexual and reproductive health? Do we call it reproductive health? Is it a women's issue? How do we support different definitions around gender and reproductive health? There are so many questions about how we conceptualize it. And a lot of what we're going to present today is an element of that, but while recognizing that it is a much more broad and inclusive area, and it doesn't exclude men either. But we're really going to focus on the parts of reproductive health that really pertain mainly to women. So there we are, state of physical, mental and social well-being in all matters related to the reproductive system, and supporting a satisfying and safe sex life, and also fulfilling reproductive intentions and choices. So very much a sort of empowering type of definition rather than too much of a medicalized definition. So we wanted to start from that kind of perspective and move it away from the contraception focus. Next slide, please. So, of course, 51% of the population are women, and all women have some kind of reproductive health needs. So that is a given. And I always like this, I use it a lot. This is from Kay Welling's work, which was based on NatSal, the NatSal 3. And it was really from a cross-section, which NatSal was, the National Attitudes and Lifestyles Survey, Sexual Health and I can never quite coin exactly what NatSal stands for, but Sexual Behaviours Survey. And this is looking at where people are in that snapshot in terms of their fertility intention. So these different bars are the different age ranges, and you'll see that people, as they go through the life course, they have different areas where they are, whether they're intending to be pregnant, as in the red band, whether they're definitely not trying to be pregnant in the purple, blue, and sort of flesh-coloured band, where they're not fertile or where they're not even sexually active. So in terms of response to that, we really need to be mindful that we're looking at a population with very, very different needs. Next slide. So second principle, that we're not just trying to prevent people getting pregnant or help them getting pregnant if they want to get pregnant, or supporting them through pregnancy. So the concept that women are just reproductive vehicles is really important to move away from. And for around 15 or 20% of women, actually managing their reproductive symptoms is the greatest concern for them. So this was based on a survey that we did, that we pushed out through Public Health England when we were doing these needs assessment. And we had about 7,500 people respond. This is a sample of 6,000 of them, and saying what actually is your most important reproductive health issue. And for young women, definitely it's the not getting pregnant. But as women get older, they care more about having an enjoyable sex life, they care more about attending screenings, and they care more about other reproductive health symptoms. Actually, women of all ages care about their symptoms, because clearly that impacts on their work life, their social life, their sex life, and their well-being. So next slide, please. So, and of course, as the other slide highlighted, this is a life course issue. So how can we support young and adolescent women to have fulfilling and happy reproductive lives as they go forward? And how can we help people at the other end of that life, the sort of later life stages, move into older ages and feel well and manage reproductive symptoms around the menopause and into old age. Next slide, please. And this slide is so overused, but I still like it. I think that it is really important, in the sort of words of Michael Marmot, is thinking about concepts of proportionate universalism. So we know that it's not equal for everybody. And although we'd like equal outcomes for everybody, we know that some people are going to need a little bit more help. Some people are less well served, and we reach them less well. And I think that it's really important it's beholden on us to go out and find those people that we're not getting it right for, and try and put a little bit of extra energy into getting that better. So I think that the new OHID is the Office for Disparities, and I think we will really have a commitment towards trying to do that work better going forward. Next slide, please. We also did some, as well as the survey, we also did some focus groups. And I wanted just to credit my colleague Carla Sankey for doing this. She's now left us, but she did some very good work. And I really just wanted to highlight the tension between taking a population approach, yet reaching the individual needs, that we can't homogenize an approach. So it's always a tension, isn't it? And I work in clinical practice and I work in public health practice. And there is a constant conflict between providing people with person-centered care and tailoring it to their own needs, but making the best decisions to reach all. And there are compromises on both sides. And this was just really illustrating the quotes from people of different ages around their contraception needs. So, you know, on the one hand, you might have a woman who really wants to carry a child and can't, and that doesn't feel like she's a woman because she's unable to have a child. And someone who's just had a child of the same age who is absolutely, the idea of being pregnant is abhorrent at that point to her. And then the third perspective of someone who is in a situation where actually this is not necessarily an autonomous decision for her. This is shaped by her family and her relationship, and how to help her make the best decision for her, given that she would only have contraception if her husband wanted her to. So those things are really difficult and nuanced challenges that don't respond easily to a sort of public health and population-based approach. Next slide, please. So the last bit of our needs assessment was to pull together, and we carried out a Delphi consensus process. So we got a range of stakeholders across the spectrum of reproductive health to try and develop some agreement around what was reproductive health going to mean for Public Health England going forwards, and hopefully more broadly going forwards. And so we, I don't know how many of you are aware of a Delphi process. I'm sure most of you are, but we put out a set of statements about what the meaning of reproductive health was, and thinking about the responses that we'd also had from our users. And we, from that, defined 6 pillars of reproductive health, which I won't go into in a lot of detail, but there is a publication that is called Reproductive Health. Well, there's a suite of publications called Reproductive Health as a Public Health Issue. And one of them is the consensus process, one of them is a sort of needs assessment, and one of them is the results of the survey. So we've got 6 pillars here, and the structure is modelled on the Dahlgren and Whitehead model of public health.
I think we've lost the ability to hear, haven't we?
Yeah, I can't hear Sue either.
Has Sue dropped out?
Yeah, I think she
screen-wise
might
as well.
Dropped off.
So it's just probably have to wait.
Yeah, sorry, that's me because I can't. Yeah, she's just texted me saying she's lost connection and she's going to log back in. So if we're okay to wait for 2 minutes, otherwise I'll pick up.
Okay, thanks, Lydia. I guess if it's a quick reconnect, then that's not a problem at all.
Yeah, great. We'll just give her a minute or so. Thanks.
Are you in contact with Lydia by text then?
Yeah, exactly. She just texted me. I'll give her till. I think she's having connection problems, which I also am as well. Maybe it's because we don't normally use Zoom.
Okay.
It should be fine, hopefully.
She's come, I think.
There we go. Hello, Sue. Can you hear us? Hey, you're back.
That's really not what you want to happen, is it? I'm so sorry.
That's okay. The important thing is you're back with us.
You had a pause. Shall I go back?
Can you see the screen?
I can, yeah, perfect. So I think I was just talking about the consensus process. I seem to be seeing the wrong slide, Lydia. Can you just...
Oh, sorry. Yeah. Let me just take you...
Perfect.
Yeah.
Yeah, you can leave it there. That's perfect. So so like I said, that you can look at the consensus process online and just read a little bit more around the pillars of reproductive health. But I think I was just in the process of saying that it was modelled on the Dahlgren and Whitehead model of public health, the wider determinants perspective on public health. So trying to apply that to a reproductive health setting. So the other side was looking at the needs assessment on the basis of what do we know, and actually, and I think Lydia will pick this up more, but there's so little routine data around reproductive health. So we have a fair amount around contraception. We have good data around abortion and conceptions, but most of the rest of the data we have is based on research from a research setting. So we would like to have things that are much more timely in terms of changes. But we anyway drew a lot on the research and a lot on what we had to look at, one, what population needs were like, and actually what the impacts of poor reproductive health were. And I am talking here a little bit on in terms of a sort of deficits model of reproductive health. And I want to emphasize that in our consensus process, we really want to think about reproductive health from a more positive perspective and recognize that actually the vast majority of people, sometimes with some support, actually reproductive health doesn't have to be a negative thing. So we want to present a positive model, but of course for some people there are problems. So we looked at things like non-volitional sex. So as we know, non-volitional sex at a population level is extremely prevalent. And we know that the impacts of that are on health in general and mental health as well. And obviously that's a very broad brush approach to that, but we're just trying to look really at population perspectives. Unplanned pregnancy. So we looked at population perspectives on using the London Measure of Unplanned Pregnancy. There's quite a lot of published data around that now, and 45% of pregnancies are unplanned or ambivalent, and more importantly, 33% of births. So I think in the past, we've had a really strong focus on abortion as a sort of negative of reproductive health outcomes, but actually trying to shift that perspective a little bit more to unplanned births. We know that some unplanned births result in greater rates of obstetric complications and poor outcomes for babies and children. However, to caveat that, unplanned births are not, again, it's a difficult and nuanced discussion because unplanned births are not universally a negative thing. I think for some people, unplanned births are very, very important, but it's trying to support women to make the choices as far as is possible within those constraints. I'm not going to go through all of these, but we looked at infertility, we looked at menopause, we looked at screening. So these like covering the whole spectrum of the different aspects of women's reproductive health. Next slide. So in terms of grounding the programme going forward, we've coined 3 ambitions that we feel are important drivers to the programme. So one is improvement in reproductive health related quality of life. One is fulfilment of reproductive choices, and one is early identification of reproductive morbidity. So cervical screening and things like that are the obvious examples of that, but I think there's a lot more scope to try and support identification of things that may lead on to future problems for women if not picked up at an earlier stage. Next slide, please. And then the last slide is to say that, and this again is based on the Successful Teenage Pregnancy Strategy, which I'm sure you'll all be aware of, but the teenage pregnancy, 10 key factors for a successful approach. Really recommend having a look at that. It's a really good system-wide approach to a population level issue. We struggle more with reproductive health because it's such a broad area. It's not just looking at one single outcome, but drawing on some of the ways of working, we've coined these 6 building blocks through which the program is working. And I'm going to stop there and hand over now to Lydia, who's going to talk a little bit to some of the examples of some of the work that we have done since this time to build on this baseline. Thanks very much.
Thanks, Sue. Can you hear me?
Yeah, loud and clear.
Perfect, great. Having some problems, but that's all good. Yeah, thanks very much, Sue. So I'm Lydia Leon, and I'm the Programme Manager in Reproductive Health at the Office for Health Improvement and Disparities, and I work in Sue's team. I'm going to be talking to you about sort of some of the more specific work that we've been doing to deliver on the aims of the Reproductive Health Programme up to this point. Most of these tools and insights that we're going to be talking about, and that Lucy will be taking us through as well, have been published this summer in a publication on gov.uk that was called the Reproductive Health Update, I think, something very exciting like that. But if you want to know any more about this, then do have a look there. The first tool that we're going to be talking about, or the first kind of bit of work that we're going to be talking about, is around developing a new reproductive health indicator set, which Sue has already kind of mentioned, and this covers both the data and evidence work streams and the kind of inequalities piece in that system-wide model that Sue was just mentioning there. So I've just taken a screenshot here from what's actually a really excellent resource if you're interested in England population health data. I'm sure many of you are familiar with it anyway, but there's called Fingertips, which was the Public Health England thing, and I guess it will move somewhere at some point. And this is our reproductive health profile, some of the indicators of which you can see here. So we've got data on LARC, data on user-dependent methods, etc., across both kind of regional, national, and local levels. But you'll also notice from here, and I'm sure from your own kind of knowledge, that most of the available data tends to be very heavily focused on contraception provision and not on this holistic view of reproductive health that Sue's been discussing. So we wanted to therefore kind of create an indicator set that we felt was more representative of our programme of work going forward, as we knew it was really important to measure the extent to which the goals of our programme were being met. So rather than just focusing on the excellent data that come out of conception rates and abortions and contraception data more generally, we wanted to make sure that we could develop, where possible, indicators relating to the whole of our programme. So across our 3 ambitions listed here, we then pulled out what we called 10 domains. So 4 domains under ambition 1 around psychosexual well-being, absence of violence, menstrual health, etc. Our fulfilment of reproductive choice ambition had domains around contraception, abortion, and unplanned pregnancy. So these are probably the ones data sources we're most familiar with. And then our ambition 3 had a domain around the prevention of reproductive ill health. So in order to produce a set of indicators that we felt captured all of this work going forwards, we ran a consensus process in 2020 to develop and agree on these set of indicators that would cover the breadth of reproductive health. And the process highlighted where good measures do not exist. So where we've kind of got real gaps, which I think, as Sue has mentioned, it's often in kind of more of the well-being space, so menstrual health and menopause health. And it also kind of helped us identify what our priorities for work on data would be going forwards. And it also, for the first time, really recognised the importance of user-reported measures as being a really important part of reproductive health tracking and measurement to be captured in future data sets. And, you know, the key being to hear from women themselves around how they feel their needs are being met across the health system. Oh, don't know what's happened there. Okay, so just to talk about the process very briefly, in case you're not familiar, the Delphi consensus process was chosen as a low cost and robust and transparent method, which enables a consensus to be reached across a wide-ranging expert group, covering the breadth of all reproductive health topic areas that we were interested in. So to begin with, there were 50 indicators that were put out to a list of reproductive health experts across 3 panels. So there was a service provider panel, a service design panel, and a public panel, and over 100 people participated in this consensus process. So the methodology allowed the process of indicator selection to be iterative and minimise the risk of missing relevant indicators, as well as enabling the identification of some kind of indicators that were maybe more aspirational and were currently unavailable, but were considered to be critical for the future monitoring of reproductive health. So the process occurred over 2 rounds, and the selection criteria you can see here. So we wanted probably around 30 indicators across the domains that I showed before. We wanted these indicators to capture, monitor, and evaluate progress of England's reproductive health over time. We wanted them to be a variation of measures, so across service access, quality, reproductive health needs, and also outcomes. Where possible, we wanted the indicators to be measurable using current data sources, although sometimes that seems easy to begin with, and actually what a data source, what we can get from data sources, as I'm sure many of you know, becomes more complex when you start looking at it. But some are easier than others to develop, let's just say that. And part of the process was that in order for an indicator to be taken forwards from our kind of long list, over 70% of participants had to rate the indicator as having high importance. So this is our final list of indicators, which we kind of consider to now be a really robust kind of list covering all of the areas of reproductive health that we're focusing on in our programme and in England. So I just wanted to highlight the ones here that were kind of perhaps more aspirational, we can say, but also ones that we have even this year had a lot of interest in, and it's really highlighted the kind of gaps in our data collection processes. So like I said, we've got a lot of data around contraception, abortion, unplanned pregnancy. It could be improved. Timeliness certainly could be improved, but this real gap around menstrual health and menopause health, and anyone who's been reading the news recently or following anything kind of going on in Parliament will know that's been a real focus of many advocates of women's reproductive health of late. So we're really keen to improve data on menstrual health and menopause health. It's not quite as straightforward perhaps as contraception, because it's not just about getting prescriptions, it's also about impact, this kind of self-reported issue that I was talking about. But yeah, there's our 23 indicators here. Please do go and have a look at the publication if you're interested to see the full list and the full methodology. It's a really good piece of work. It was a great piece of work to be involved in, and I think it really demonstrates the breadth of focus of what we want our programme to be going forwards. And it would be really interesting to hear from colleagues around the table what sorts of indicators might have been more relevant to them in different settings. Does this kind of way of splitting up the work, I guess, is it relevant to you in different countries, in kind of lower income settings, or countries with different demographics, etc. So that would be great to hear towards the end if people have thoughts on that. So moving on from our indicator development, is worth saying that the development of those indicators is underway, and this is a long process. So much of that will be kind of iterative as we go through. So the next piece of work that I want to talk about is a reproductive health user experiences survey that we piloted earlier on in the summer. I say we commissioned, Public Health England commissioned the London School of Hygiene and Tropical Medicine to develop and run a user experiences survey. And we received over 13,000 responses to this, which was really fantastic. We ran it over 6 weeks. The kind of main work around this was in the development of the question set. So we wanted a validated survey to be developed that would expand beyond what's covered in NatSal to cover, again, our kind of holistic view of reproductive health against menstrual health, intentions, reproductive health experiences, and reproductive ill health. So we had these 4 kind of domains, again, that we covered in the question set. Around 40% of the questions were from NatSal. Which was intentional, because we do hope that we can one day run this again, and maybe if we got the funding, we could run this on kind of as a longitudinal survey, and we would then be able to cross-check it against the NatSal questions, which happen every 10 years, and obviously that's a probability sample. So ours was a non-probability sample approach, if you can say that. It was a digital, it was run through social media, so it was advertised on Instagram and on Facebook, and anybody who wanted to could join. And the school were kind of tasked with trying to ensure as representative a sample of women came forwards as possible. So they used a number of different sampling strategies and worked with different advocacy organisations to try to see how they could ensure that the people who we got responses from represented the population as a whole. Unfortunately, as is often the case with these sorts of national surveys that are delivered digitally, we didn't reach all the women that we wanted to, and women, particularly women who identified as being from Black and Asian ethnicity, younger women, and those from lower educational backgrounds were less well represented compared to the population census figures, which I'm sure, unfortunately, won't surprise anybody. But we and that was kind of despite really trying to do some targeted work, at least with the targeting of our adverts as much as we could. But we do have some planned work to try and get some funding to address this low response rate from certain groups, in specific groups, particularly those who have the poorest reproductive health outcomes. And this might involve using this survey instrument in more of a face-to-face capacity, considering kind of the impact of digital exclusion, or considering the need to kind of target publicity for certain groups in a kind of specific and culturally sensitive way. So that's kind of next steps, but the final question list and the survey instrument is also going to hopefully be made available for use by partners at a local level. So we're hoping to publish the question set, and that can be, we already have interest from several local authorities, including Sue's, you'll be surprised to hear, that might be running this survey in the future. And that will be really, really great to see it used in more of a kind of local needs assessment way, as well as at this national level, because they both of those views are so important, but they do slightly different things. And again, kind of putting it out to the group, it would be really interesting to hear, and for colleagues to kind of have a look at the question set, see whether it would also be a framework that would be useful for international work. Of course, it would need validation, but we think it's a really great starting point to start to ensure that women's voices from across the spectrum are really heard in terms of their experiences of both their own reproductive health, but of the services that they try to access. So finally, I'm going to talk about a tool that was developed by our health economics colleagues when we were at Public Health England. It's a really excellent team that do a lot of work around trying to estimate the return on investment of certain interventions across the public health system. Of course, this is a really important thing in policy making, kind of demonstrating the cost effectiveness of certain interventions over others. And in 2018, there was the original model that was developed by the health economics team and Sue's team at the time, I believe, and it demonstrated a really significant return on investment for publicly funded contraception. So invested in publicly funded contraception, there was a £9 return for the whole system due to the aversion of unplanned pregnancies, which obviously have high costs for the health system and wider society. So we wanted to extend this and relevant additional scenarios that we're interested in looking at more and kind of making the case for more in our team and across kind of public health, reproductive health policymaking. So one of them is the provision of contraception in maternity settings that we know is as an intervention has been much more widely implemented in low and middle income settings, and in the UK it's been post-abortion contraception has been pretty well implemented. However, it's not currently well implemented in maternity settings. There isn't a kind of a sustainable funding model for it, but it has been gaining traction as an important option for opportunistic contraception care that will have a real kind of ability to reduce inequalities and potentially address unmet need in women who may otherwise not have used contraception. So unmet need around 10% in England, which I'm sure is a lot lower than other settings, but there is still a significant number of women who may want to be on contraception but aren't able to access it.
So Lydia,
so we think that this would be a really excellent way of doing that, and the ROI of that is a staggering.
Lydia, you're dropping in and out, particularly on this slide.
£32 investors. Is a model setting. So for every £1 providing additional LARC, there's a £48 return. I think in both these cases it's so high because you're more likely to get women with unmet need, and also they're really relatively cheap interventions. Both of them are very relevant policy at the moment. LARC in primary care is something that has been an issue raised over and over again with us from primary care stakeholders, both prior to the pandemic, but definitely since the pandemic. It's been a real issue in terms of women accessing long-acting reversible contraception, both in terms of getting these contraception fitted and in removals.
Lydia, just to flag, you're very much dropping out.
Am I dropping out?
Yeah. On this slide in particular.
Did you say I'm dropping out?
Yeah, it seems to be progressive as well, so it's getting worse and worse.
Hi. Can you hear me? Can you hear me?
I'm having trouble. I'm not quite sure if that's consistent for everybody. Is everybody having a bit of trouble with Lydia? Yeah.
Yeah, I think it's difficult to hear. I wonder, I think the next slide might be Lucy. Is that right, Lydia?
Yeah, I think Lydia had one more slide.
I think it might be a case of dropping out and rejoining us. That can sometimes work.
Okay.
Oh yeah, she said she's going to pass on to me. I will.
Okay, I might try and pass on.
Yeah, I'll share my screen.
Is that okay, Lucy? Can you take that up?
Yeah, for sure. Lydia, Thanks. If you want, I can share the slides for mine so that you don't have to worry about.
I'm going to pass on to.
Lucy, do you have the slides that you could share from your screen?
I do, yes. I'm just trying to share my screen, but it says that I can't start screen sharing while I think while Lydia's got hers. So yeah, Lydia, if you can still hear us, don't worry about sharing the screen. I can do that for my slides. While we wait. So I might as well just start speaking, and then if Lydia drops off, I will and try and get my slides up instead. What I'm going to do is I'm going to talk to you about a toolkit that we developed. This is very much from a behavioural science perspective, so a little bit different. Now we're thinking about how we can use behavioural science to create interventions and services that best suit women's needs. And what I'm going to do is I'm just going to pop the link to this toolkit in the chat. Oh, there we go. I'll just share my screen as well. There you go. Okay, let me know. Can you see my screen okay? Yeah, okay, I can see Sue nodding. Right, I'm going to go into full screen and then I won't be able to see you anymore. So shout at me if anything goes wrong. Oh, I can still see you. That doesn't normally happen. So yes, as I was saying, so this is very much a toolkit that's about using a behavioural science approach to trying to understand how we can create services and interventions that best support women and their needs. And this was a piece of research that was commissioned out to researchers at Warwick University. And they led this research and really undertook the bulk of the work. So I just want to acknowledge their work in all of this. And the key questions we had at the outset were what are the barriers that women experience when they're seeking support in 3 different areas. So we were looking at reproductive symptoms across the life course, and that was a really, really broad area. It could be anything from symptoms related to heavy or painful periods. It could be related to menopause symptoms. It could also be related to infertility. So that was a really, really broad package. The next topic was choosing a preferred method of contraception. And then the final one was preparing for pregnancy in terms of actions like taking folic acid. And what we really wanted to understand were what are the barriers that women experience when they're seeking support. And by support, really we meant a very, very broad definition. It could be going to their GP or accessing sort of more formal reproductive and sexual health services, but it could also mean simply turning to friends and family or using more informal sources online or on social media. And we also wanted to understand, what kinds of intervention can better support women to access this kind of support for their reproductive health. So these were the questions that we started out at the outset. And I'm just going to talk to you a little bit about the method underlying the research in this project, and then also talk to you a bit about the development of this toolkit that I've shared the link for. So for the 3 topic areas, the academics at Warwick University conducted 3 individual systematic reviews. And here we were really looking to identify papers that described barriers and facilitators experienced by women when seeking support. And these papers were, once they were identified, any text inside the paper that described barriers or facilitators was extracted, and a thematic analysis was conducted with the goal of generating a list of different barriers and facilitators that represented a synthesis of all the information from the different papers. Now, once we'd got these barriers and facilitators experienced by women, we then started using the behaviour change frameworks, and we coded them into mechanisms of action. Now, if you're not familiar with the UCL's Theory and Techniques tool, which is where we drew our mechanisms of action from, it's related to the behaviour change wheel, so I don't know if anybody is familiar with that. But if you're not, just to really just try and describe it at quite a high level, you can consider mechanisms of action as just being types of influence on behaviour is probably the simplest way of thinking about it. And I've put some examples in the diagram on the screen. So examples of mechanisms of action could be social influences, beliefs about the consequences of performing the behaviour. So in this case, reaching out for support. It could be about the environmental context that women live in or the resources that they have access to. It could be about knowledge, etc., etc. There are 26 mechanisms of action in total. Now, the reason that we group barriers and facilitators into these mechanisms of action is so that First of all, so that we have similar ones grouped together, it just makes it easier to kind of make sense of the findings. But also, if I just move on to the next slide, this shows the theory and techniques tool, which is where the mechanisms of action were taken from as a framework. And you can see here that we've got a matrix. Now, what this is doing is it's linking up mechanisms of action to suggested behaviour change techniques that could, in theory, target those barriers. So we're kind of using mechanisms of action as a way of combining similar barriers and facilitators together, but also as a mechanism for finding what kind of intervention strategies could we use. Now, as I mentioned, there are 26 mechanisms of action that we could be categorizing our barriers into. It gets a bit more complicated when it gets to the behavior change techniques because there are over 70 listed in the theory and techniques tool. So there's a lot of information here. And as you can probably imagine, from having conducted 3 systematic reviews, we ended up with a lot of barriers. To complicate things further, each barrier could be associated with more than one mechanism of action. And each mechanism of action, in turn, is associated with lots and lots of behaviour change techniques. What this means in the end is that we had a lot of information, a lot of findings, a lot of potential recommendations to communicate to the audiences who could potentially benefit from this work. So the next question was, how do we translate this? And you'll notice that here I'm not even going to attempt to describe our findings in this presentation. This question here was, how can we communicate this in a way that is usable and doesn't make this information completely overwhelming in the breadth and depth of it. So this is where the toolkit that I shared the link to and that I'm showing you today comes into play. We work with a research communication agency called Research Retold, who essentially helped put our findings into this really fantastic interactive PDF. It essentially works like a mini self-contained website, and I'll give you a really quick demo in a second. But we were really aiming this toolkit, anybody at all involved in, for example, planning or commissioning, designing, delivering and evaluating interventions and services to improve women's access to reproductive healthcare and support for the 3 topic areas that I mentioned at the beginning. So when you think about the kinds of audiences that we're aiming this toolkit at, it could span national and local public health teams, it could be practitioners delivering services, it could be organisations that are commissioned to design and deliver services, but of course it could also be academic researchers who are also involved in planning, designing and evaluating interventions. And so it's because of this very, very broad audience that we didn't want to make a decision at the outset about which barriers we were going to present or which behaviour change techniques we were going to present. We really wanted to present the full findings because we recognised that each individual team might have specific needs, they might have specific knowledge of which barriers they needed to focus in on, but they also likely have different resources and different possibilities available to them as to what they can actually do. So I'm just going to come out of the presentation and show you what this actually looks like. So can you see the toolkit that I've just pulled up on my screen? Okay,
so Lucy, we can see the first page there.
Fantastic. So what I'm going to do is I'm just going to scroll through the opening sections because this just really provides you a bit more background on the research project, a little bit more information on how to use the tool. I'm not going to pause there because I'm speaking to you about it now. And I'm going to just bring you down here to this first instruction page, which basically tells you how to navigate the interactive element of the toolkit. As I mentioned, it works like a website. So I'm going to click this button here, and it's going to take me straight down to the section on choosing and accessing contraception. And you see along here, we have a menu along the top so that I can flick through each of the different topic areas of interest. But for now, just for this demo, I'm just going to stick with the contraception topic. Now, we've landed on the first mechanism of action. That's environmental context and resources. And you can see here that we've got a list of the barriers that are identified, the facilitators that are identified, and then also factors that were considered to act as facilitators and barriers occasionally. And then underneath this, we have lists of all the different behaviour change techniques that could be used in services and interventions to target these barriers. And again, as can be imagined, there are lots and lots of recommended behaviour change techniques. So we do sometimes have different tabs that can be clicked through. Along the top up here, just underneath the main menu, we've also got all the different mechanisms of action. So you can click through those, see all the different barriers we found, all the different behaviour change techniques. And you can also see that there are differences, so not all of the mechanisms of action have so many barriers or so many behaviour change techniques associated with them. So that is a very, very quick whistle-stop tour of the toolkit itself. If I just pop back into the slides. So you can probably tell by looking at the toolkit, even though we've got this really great interactive resource, there's still a lot of information in there. There's still a lot of behaviour change techniques potentially being recommended for use. So how do teams sift these further? Well, probably simply by looking at the list of recommendations. Teams will probably straight away be able to tell whether that's something that they can implement. But even then, they may still end up with a long, long list of potential techniques that they could be implementing in their interventions or in their services. So we've also included a worksheet using a framework called APPEASE, which is a set of criteria that can be used to help prioritise which strategies to go for. And again, the APPEASE framework is linked to the same to the theory and techniques tool that I mentioned earlier. It's part of the set of tools created by UCL's Centre for Behaviour Change. And it's essentially, you can see here, we've got a list of criteria of acceptability, practicability, effectiveness, affordability, side effects, so that's positive and negative side effects, and equity. And we've just created this worksheet so that teams can work through the potential behaviour change techniques that they might want to use and just rank them based on these different criteria to then finally select the ones that they do implement in their intervention. I just wanted to finish up by sort of zooming back out away from the toolkit and just mentioning a couple of other points regarding the research project that underlies this toolkit. So as well as creating lists of recommended intervention techniques, we also conducted an evaluation of existing national interventions and just looked out for essentially, which intervention types were already being used in practice and where there might be missed opportunities for further resources to be directed towards in future, which allowed the academic team at Warwick to produce a list of broad kind of strategic recommendations for intervention and service provision. An additional area that we were really looking at the beginning, and one of our intentions right from the outset, was to look for literature specifically exploring barriers and facilitators experienced by Black women in the UK. Because of course we know that unfortunately Black women in the UK do experience poorer reproductive health outcomes. So we really wanted to explore, what are the specific barriers and facilitators experienced by Black women in the UK. Unfortunately, one of the findings of this research was that across all three streams, there was only one study that was identified in our search results that had a sample of specifically exclusively Black women. And that focused on menopause. So unfortunately, we weren't able to fulfill this intention of exploring these experiences. And one of the calls that we have from this work is that there is a need for more research to explore the experiences of Black women in the UK. While we're on the point as well, speaking about which groups are, whose experiences are represented in this piece of work, it's also worth noting that throughout this project, when I've used the term women, we've been specifically referring to those women who were assigned female at birth and still identify as women. And that's because, as you can imagine, from the specific areas that we were looking at, such as reproductive symptoms around periods, menopause, planning for pregnancy, these are all very much connected to having a uterus. But we do recognise that, of course, these reproductive health issues will also be relevant for people who don't necessarily identify as women, such as non-binary people and trans men. And it's just important to note that our specific search strategy won't have picked up research that might have been conducted with these groups. And we really do recognise that it's very, very important to understand the experiences of people who may not identify as women but do still have a uterus and have these reproductive health needs. But of course, the barriers that they experience may be very different to the ones that cis women experience. And so we would also suggest that a bespoke piece of research with a bespoke search strategy is conducted to understand their experiences too. And just to finally say that the contraception stream of this work was published open access this week. So I've put a link to that in the slides as well, in case you'd like to follow up. But I think that's enough from me. So I'm just going to pass back to Sue now for the final thoughts.
So thanks so much for listening to us. And that's just a little bit of a flavour of some of the things we've been doing. So I just really have put some final thoughts up there and things that we might think about together. So I suppose we're interested in a few things, but really interested to hear what your responses are as well. I suppose we're wondering on next steps. So we're thinking about how we can further progress the work that we're doing and how what we've already done can be developed. We're really keen to make sure that the tools get used, both in research and non-research settings. And as already been highlighted, we really want to try and use them and validate them for populations that we don't feel that we've reached so well. We're very interested in collaboration, so both in terms of policy research and looking at those specific populations that I've talked about, and also interested to hear your thoughts on the main research gaps and what you think the main policy gaps might be, and what the work that you're doing might bring to that. So really interested to hear your thoughts on any of those things, or indeed anything that, any comments you've got. So thanks very much.
Thanks, Sue. Thanks, Lydia and Lucy. We can open the floor to questions, and what I just say, just practically in terms of asking questions, there's an ability to raise hands on Zoom for those who are unaware by the reactions button at the bottom of the page. If you click on the reactions, which is a sort of smiley face, it gives you an opportunity to raise your hand. I'd like to sort of say to all three speakers, it absolutely wonderful presentation, and I'm sure it will spark discussions. And I think having that slide at the end in terms of what topics that we could frame questions in is great. Could I maybe, just while waiting for people to raise their hand, just lead off in terms of a gap? This is probably a very naive question, so apologies for asking it. But in terms of the remit and definition of reproductive health, maybe it's because you had an age range there and it was 18 plus. I think that probably how things sort of kicked off initially, Sue, with your discussion. I really fundamentally understand that the nature of reproductive health can change, the focus of reproductive health can change during the life course, and that need to move away from a focus entirely on contraception is completely understood, and the importance of menopause there, undoubtedly that's increasing. But it is, in terms of at the very beginning of our life course and puberty, I just wondered, is there any particular focus on that or discussion to be had about that? Because I can sort of appreciate for girls that transition presents lots of issues that you've raised. It's multifaceted, and simply is puberty completely off topic when we talk about reproductive health? And if it isn't, how does it bear with the lots of the things that you're doing moving forward? So I've got that particular question around where does puberty fit? And the other is, what's the relationship then with reproductive health in relation to obstetrics? So it's almost like we have a lot of issues to focus on that are leading up to pregnancy, either preventing it or inducing it. And then we have this black hole of pregnancy. And then we come back the other side, and then we start to talk about reproductive health postpartum. And I just worry, is there a way of dealing with that connectivity of reproductive health being also pregnancy-related reproductive maternal health? Or is that just simply off focus? Because if it's off focus, surely there are intersections between the two. So is that sort of two questions about where does puberty lie, and what do we do about the obstetrics side of women's reproductive health?
Thanks, Keith. So I'll go for that one. So both really great questions. So I suppose on the first one, we spent a long time discussing, age range and whether actually you should put an age range on the issue. And at one point we talked about from puberty to menopause as being our sort of time span that we were thinking about. I think puberty, you're absolutely right, is an utterly essential phase, and obviously sets the scene for future reproductive life going forwards. I think a lot of our focus from a policy perspective has been around supporting good RSHE. So thinking about how do you support young women going through puberty to understand what's happening to them, and think about how they can build on those basic blocks going forward. Now, of course, that information also starts way pre-puberty, but I guess being prepared for puberty is really important. So I wouldn't want to actually put a lower age limit on it, but I think that for the purposes of thinking about reproductive health more broadly, we make an assumption that we start from puberty, but it has a relevance for younger people coming through in terms of what they understand and know about their reproductive health going forwards. So I would try to avoid a kind of lower limit, but a broad understanding that it really starts at puberty. And to your second point, yes, definitely. So I think this is where the complexity comes in. So I think particularly from a global point of view, reproductive health is very much focused around pregnancy and postnatal and delivery and maternity care. I think it's a symptom of the way that the system is chopped up and the way it's siloed. And we know that certainly from a policy perspective in England, there's been a huge focus on maternity with the Maternity Transformation Programme. And what we sought to do with a public health perspective was to say, okay, this area is definitely part of the broader reproductive health framework, but what we're trying to think about is a population approach to supporting good reproductive health outcomes. So not, in a sense, we've avoided gynecology and obstetrics because that's almost a more biomedical approach to aspects of reproductive health. However, when you're thinking about the preconception space and you're thinking about the postnatal space, that very much is covered. And I wouldn't want to exclude pregnancy and childbirth. It's just that they sit in policy separate areas, and what's been really under approach from a public health perspective has been actually how does the health of women more generally foster good pregnancy and obstetric outcomes. And a lot of that work is so much more upstream. So when we think about things like stillbirth, low birth weight, preterm labour, actually so much of that work could be done upstream before women are even thinking about having a pregnancy. And indeed, in the preconception period, when people are trying to be pregnant, there just isn't enough time to impact on that. So all the impacts are around healthcare. Whereas before that time, the preventative health is much more, there's many more opportunities to actually impact on pregnancy outcomes.
Thank you, Sue. I'm waiting for any hands up, but I noticed Louisa had something in the chat. So, Louisa, did you want to come in and ask a specific question?
Really sorry that my mic is not very good today, and I have no camera either. So I'm Luisa Zuccol. I'm an epidemiologist at the University of Bristol, Department of Population Health Sciences. I thought your presentations were outstanding. It was great to have this overview of the public health intersection with the reproductive health sphere. My comment was mostly about the early postnatal period seen from a public health lens. And my interest lies in infant feeding and how it intersects with postnatal mental health, which obviously is something that's amenable to public health interventions. And I was wondering whether I guess maybe just adding indicators or cross-referencing indicators with the available maternal and child health at former PhD on infant feeding and also mental health, or whether you think you just see yourself as you just explained as sort of siloed in different ways.
So there are some really good public health indicators around maternal and child health, which we certainly will be drawing on some of them for our broader indicator set. So I don't know if you probably already know about maternal and child health indicators, but there are certainly some postnatal mental health ones, and certainly some, there's a number of breastfeeding indicators. So I don't know, Lydia, whether you want to add anything on that in terms of our own indicator set, because I think that postnatal period and indeed interconception care is such an important opportunity, again, to support improved outcomes going forward and in subsequent pregnancies or not. But also you raise the kind of issue about intergenerational outcomes that aren't just from maternal health, but are also about the relationship and the support going forward. So I think a number of really interesting points being raised. And in terms of indicators, I think Lydia might have more idea about what's available and what might be useful.
Yeah, I mean, from the indicator set that we've got, the kind of ones that we consider to be preconception outcomes, I guess, are probably a bit reductionist in terms of their low birth rate and neonatal mortality and stillbirth. So we don't, as you say, kind of go into those key issues around kind of postnatal mental health. We do work quite closely with our maternity team, both in kind of on the policy side and also on the data side. And I think often the outcomes are the bits which we share, obviously. So, poor reproductive health outcomes are the same if you're talking about kind of lack of access to contraception or poor kind of pregnancy care. But yeah, I think we haven't explicitly pulled that out in our Delphi process. We had to sort of choose, I guess. But one thing I wanted to raise was we've been doing, somebody in our team who's not here today has been doing some really excellent work in terms of scoping the wider determinants of health impacts on reproductive health of women, but presumably they would also really kind of impact upon pregnancy as well. So really trying to kind of pull out even further, I guess, and think about the impact of social determinants on outcomes, so housing and income and work and things like that. So that's again where I think it really crosses over reproductive health and maternity. But yeah, it always feels a bit ridiculous to be doing the cut-offs, but it has to happen somewhere, I guess.
Louisa, your hand is up now. Did you want to come back?
Yes, because I had a follow-on question, if that's allowed. I'm sorry.
Yeah, absolutely.
I
wanted
know
if
she
she wants
also
to come
has her
back.
hand up. Thank you. So my follow-on question was about availability of data and whether you are aware of any efforts to try and gather data from the electronic child records. So what used to be the red books and are now in a very sort of area-based way are coming online, and most of the postnatal indicators that the maternity team has come from directly sort of passive data collection from the health visiting teams, and they've been of really poor quality in the last 5 years, especially since COVID. And so I was wondering whether individual level data that are collected through the child records in sort of in parallel with the maternity transformation, whether you have any awareness, or sorry if it's beyond your remit, but just a thought about that.
No, it's a really good question. And I think that what might be good would be to, because I can certainly put you in touch with the team who look after those indicators, and they will definitely be able to answer that better than I can. So please do feel free to drop us an email, and we can definitely pick that up with them.
Great. So waiting very patiently, Chi, you're wanting to come in for a while.
Thank you. Thanks very much, Peter. Deeply enjoyed these presentations. Thank you very much. And I'm Chi Esiefro. I'm from Global Health and Infection at Brighton and Sussex Medical School, and also working in international collaboration with East African countries in the UK, looking at menstrual health from a very holistic perspective of the definitions of menstrual health and exploring the definitions, more specifically in adolescence and the intersections with human rights in general and adolescents' rights. And I think, and so therefore quite interested in the how the intersection between these indicators in the international perspective, across the international perspective. So maybe some further discussions to be had. And just quite a simple question, really. I remarked and enjoyed the perspective, the live course perspective and the reproductive issues, the emphasis on reproductive for perspective of women through the life course, and the more positive aspects of the holistic definition of reproductive health. So as women age through the life course, we're more interested in healthy sex life. And that was really quite prominent, Sue, in terms of proportions of women and how that represented their perspective on reproductive health. But I saw a dearth of indicators for that. And that the indicators seem to look more at morbidity and perhaps more negative aspects of the definition of reproductive health. And I just wondered why we think we have a dearth of indicators for the more positive aspects of our definitions of reproductive health, and what the value would be in defining these indicators.
So I'll kick off there, but I'm sure Lydia and Lucy might also have some thoughts about it, because they're really, really interesting questions. And I think, unfortunately, that the approach to reproductive health has always been from a biomedical perspective, and therefore it relates to outcomes, risk, access to care, and those kinds of things. And so when we try and think about flipping that balance, the only way that we can really get the indicators is to develop the self-reported measures, because there isn't really any other way of doing it. And I guess that was the driver because I absolutely agree your point, and the driver for developing the self-reported measures was very much saying, well, how can we have a positive model and demonstrate that we are improving on that level without having any ways of measuring it? So, and if you've got any ideas about that you can also add to that we'd be really, really interested to know. So I think we would love to share the survey with you, because I think also for your work around menstrual health, there's some really interesting measures in there, and there's a period poverty measure although I don't really like the term period poverty. It's poverty, isn't it? Access to menstrual products. There's some measures about impacts on sex, well-being, and life in general from menstrual loss. And I know from a perspective of my clinical work that, I will see people come in who have periods that are so heavy that, they fill their shoes, but they don't know whether, how to make that better and live their lives better, other than, is this normal or not normal? So it's trying to support women to understand norms and things that are a bit more difficult but might not be disease, and how can those things be supported to be better. So I think we're a long way from that, and so I really value some of the comments that you're making. Really happy to give you some more information that we've got around the sort of menstrual indicators, but it is a problem saying you've got a positive approach and then saying actually but we can only measure hospital admissions and hysterectomies, or and the other, just the last thing I want to say about an observation is I've been doing a lot of work around the menopause, and actually what you can find is a similar thing works in that, if you support women to understand the changes that are happening around their menopause and what to expect, and also see it as a life change and a reframing. Actually, a lot of the women that I work with come forward with a lot of kind of positives around that period of life. It's a difficult time, and there can be some annoying physical symptoms, but still there are it's a way of looking at that in a slightly different way. So I'm really keen that we try and push forward this and try and say, okay, yes, there's some ill health, but it's not everything. So yeah, I don't know, Lydia and Lucy, sorry, that's hogging it a bit, and please do come in.
Yeah, I think it's a really interesting question about the positive, how to kind of measure the positive outcomes. I guess the thinking that we've done in this space, or the thinking that I've done in this space more recently, which is very surface, has been around trying to think about the needs of older women and their changing kind of requirements of contraception as through kind of relationship changes or relationship breakdown, and whether we have enough of a focus in terms of information provision in that kind of age group, because often we focus so heavily on young people, and actually there is some evidence in the data that maybe there is an unmet need in older women in terms of contraceptive needs specifically, but presumably across navigating new relationships, having a positive, having positive and enjoyable sex lives as you age. And I think that that's something that really I'd be interested in us doing more work on. Certainly, we've got a colleague who's really interested in that. And I think that in terms of the positive, maybe not, we're not quite at positive metrics yet, but positive health promotion in that space could be a place to start.
Chi, did you want to cut? Lucy, did you want to comment, or Chi, did you want to come back on anything that you've heard?
Thank you. Just speaking really to, it's almost like the elephant in the room, because the positive indicators, the positive impacts of the positivity of every aspect through the life course, reproductive life course, if not spoken to and if not defined, it can't be improved. So
great, thank you. Rebecca, you asked a question in the chat. Did you want the speakers to read that and answer to it, or did you want to add anything to it before?
I'm happy to ask it live if you like. I kind of understood from Sue earlier that the focus on this isn't really around sort of the preconception period and pregnancy necessarily, because it's too late. But I thought what she said earlier about kind of balancing individual with societal needs, both across sort of clinical and public health practice, was really fascinating, and something that I think about a lot as I do work on public health and pregnancy through the RISK project. And something that I'm always fascinated by is this kind of the trend in all areas of public health to focus on the social determinants of health. And we do this even when we talk about the outcomes of Black women being particularly poor in maternity care. But that kind of trend and that focus doesn't seem to be compatible with any of the efforts to improve pregnancy outcomes and the sort of interventions that we see in the preconception and antenatal period, which just seem to be wholly focused on individual level behaviours. And it always really frustrates me that it's a kind of, I have a rather rude term for it, I guess, really, but it's just a complete kind of, how would I describe it? A kind of a confusion of what public health is, really. And I just wonder why we set those kind of core principles aside when it comes to pregnancy. So I thought I'd just ask this question while I had people here that probably think in the same way as me, or maybe don't, but may have come across this issue.
Yeah, so I'll speak to that first, and unless Lydia and Lucy, you want to come in. I think that is such a sort of key question, isn't it? And I think the Risk Project and what it has uncovered, and I don't know how many people here are familiar with it, I'm sure a lot of people are, but I think it's been such an incredibly important bit of work, and something that I find a constant struggle in terms of how the whole approach towards risk and personal risk versus population level impacts. And I think when we talk particularly, I know Risk focused on this a lot, but when we particularly talk around weight management, I think that's where all the concepts of individual level behaviours and blames and risks become sort of concentrated. So I suppose, what are the more public health approaches to support better how those population level impacts are managed? I suppose that is our challenge. And as Lydia mentioned, we are starting to try and think more broadly about scoping out how can we think more broadly about the wider determinants of poor reproductive health beyond that sort of immediate healthcare encounter, but also how can we support healthcare that is dealing with individuals to do that better at a population level. So there are ways of supporting information giving and discussions to inform and empower that aren't necessarily about challenging blame. So I think public health does have a role in that. But it also has a role to say it's not just about that individual level discussion, it's about structural changes. And I think I'm going to ask Lucy to come in, because I think she can talk much more eloquently than I can about some of those more sort of structural versus behavioural level interventions.
Yeah, sure. I mean, first of all, I would suggest that it's not necessarily just around pregnancy that we have this tendency to focus in on the individual. I think there are a lot of other areas of health where interventions do tend to focus on the individual rather than looking at these wider structural and environmental and social issues. In terms of from a behaviour change perspective, a lot of our work, we do try and look across the system. We do try and, rather than just focusing necessarily on the patient or the end user, we will also try and look at healthcare professionals, policymakers and decision makers, etc., to try and identify like where in the system there'd be the greatest chance to bring about change. And similarly, the models of behaviour that we look at, they're not necessarily just focusing on individual level factors. A lot of people think, that things are. I feel like there's a tendency to believe that in order to bring about change, we need to focus on individuals by providing information to them and encouraging them, persuading them, because there's an assumption that if you just tell people what's good for them and try and persuade them to do it, then they'll do what we think is right for them without thinking about the wider environment, the wider environment, both in terms of what's physically there, what context there is, what resources people have, but also in terms of the social environment that they live their lives in. So we do very much from our behaviour change perspective in my team, we do think about these factors. I think probably part of the answer might be that the solutions to these bigger structural environmental changes will probably require more of a joined up approach across well, in government, definitely across government departments, to bring about these wider changes.
Rebecca, did you want to come back on?
Yeah.
Sue?
Just to say thank you. Yeah, and I kind of I guess the frustration for me is like the kind of obsession with pregnancy being seen as like this teachable moment where you can fix all of a woman's problems related to that particular pregnancy and potentially any future ones. And actually, with things like obesity, it is often too late. And with kind of without continuity of care as well, the woman in front of you is not often being kind of congratulated on the journey that she might have been on to get to where she currently is. And then sort of counter to that, you also have like, okay, so if it's too late to solve some of these more kind of complex, longer term problems, socially determined problems during that teachable moment, then what I worry about is like the preconception creep, where we're then kind of trying to create healthy pregnancies when a woman is not even thinking about getting pregnant, and that might not ever be her intention. And that's a particular concern to me around alcohol policies and for women of reproductive age. I just think it's a really interesting sort of balance to strike, when actually the answer to me often feels like, well, if people weren't living in poverty or in precarious housing or any of those things, then their problems wouldn't really be half as bad as they are. Anyway, thank you very much.
Thanks, Rebecca, for your question. Maya, you got your hand up.
Thanks. Sorry, thanks, Keith. I was just thank you so much for your presentation, and thanks. I've just been hearing this discussion, and there's lots of interesting stuff that's been coming up. I'm just absolutely learning a lot. My sort of general sort of comment and related to a question is more broadly in terms of what is all this doing. I mean, I know it's not about so the question isn't what you're doing is obvious in terms of making the quality of women's experience of reproductive health better, and there's no doubt about that. But I was thinking more broadly in terms of sort of the knowledge production and what is actually happening. So, I mean, I found the amount of information that you've gathered and the kind of highlights the complexity of addressing the issue, which I think is useful in two ways. One, of course, is you've highlighted the data gaps, the research data gaps, that there is so little information at all, and focus on things like infertility and the menopause. So I think that's really important for us as researchers to try and understand, where there isn't enough material, and I think that's really helpful. But I think overall also, what you've done is you've created a space of both, and this is really from a feminist lens, is created a space in which there is awareness, but there's also space for discussion that has, is generated through what you're doing. But the third issue, and this is the one that my question is around this, because I'm thinking, what is the impact of what you've done on health providers and people who provide services? And from my experience of working in India, I think you've done something really important, but you've also presented a huge amount of uncertainty and ambiguity for them, in the sense of when things are really clear about how to do things, then particularly when you're at the provider end, that's helpful. But when all this complexity comes up, I'm just wondering from a health provider end, that disruption of certainty that people would have, the rise of uncertainty. Um, how do you see that as actually being perhaps a bit regressive? So, for example, in the context of India, where health workers are really concerned about ticking boxes. We have to meet this, we have to meet this, we have to do that. And sort of linking also to what Rebecca just mentioned here about, then creating something else in that process of addressing these issues, making things either sort of more forceful or not. I mean, I'm just wondering, I'm wondering how the particular, how providers here would see the incredible sort of complexity that you've brought out here. So that's just a very general question. Thank you.
So again, I'm sure we've all got thoughts on that, because it's a really interesting question. And I think the first thing I would say is it's very early days. So I think that there is a sphere of influence that happens at national, regional, local, and provider level. And it's much more of a drip effect than creating an immediate kind of uncertainty and throwing it all up in the air. So there are some very, I think providers, you're right, are utterly driven by ticking boxes. Commissioners are utterly driven by what is, so hence the return on investment tools, really. How can we encourage commissioners to commission services so they reach all women with contraception if they need it? Well, give them a return on investment, and then they'll go like, well, this looks like a good idea. So trying to provide that combination between a kind of gradual shift in the culture and the underpinnings of how we see population level reproductive health, mixed with we are where we are. We're sitting in a system which is very, very old-fashioned and slow to move. What can we do with that? And just speaking from some personal experiences, there are ways of also, I think there are some carrots in there, which can be quite skillfully sort of, if you talk about it in terms of taking the strain off, releasing some capacity, supporting women to self-manage in the community, and therefore stopping them utilising healthcare. So we did some interesting work around some group consultations for menopause, and we looked and saw that in the 6 months prior to the group consultations, women had an average of 2.7 consultations with their GP about related issues. So if we can sell some of the, because of course it is making people more healthy and making them positive about their reproductive health and taking away a medical focus will ultimately impact on their healthcare usage. But I'm not kind of so deluded that I think that will happen immediately. But I do think, yes, retaining some certainties and accepting that box ticking is going to be the bread and butter. So change the boxes, and help people to see it in a different way, try and reframe it, try and slip things in on the side that, make it a population approach rather than just a healthcare approach. So I think there's a number of things we can do without saying we're going to turn it all upside down and start again, which would be the much preferred option, I think. But, that is where we are. So I suppose that's just my kind of personal thoughts on it, but I'm sure Lydia and Lucy, you've also got some thoughts on that.
I think it's interesting the idea of kind of bringing what the providers think, because actually we get quite a lot from the providers saying that they really welcome, that they want more of this approach at a national level, that they actually feel like something coming down that's about holistic care and women not bouncing around the system, and it being across the life course, and it not being kind of gynae separate from this, separate from that, is, from the providers that we speak to, who granted probably are women's health interested providers, largely, that there is a kind of appetite there, and there are lots of bottom-up approaches that are including, as Sue's talked about in kind of her patch and across the country, in terms of trying to provide this more holistic reproductive health care approach in an actual setting. So women's health hubs being one example of that across different settings. So I think it's kind of maybe a bit of a pincer movement of interested grassroots work and a kind of acknowledgement at the top, and the drip coming in both directions, perhaps, to support each other. I don't know if that makes sense.
Maya, did you want to come back on what Lydia
No,
said,
I think that, no, thank you very much. That was really good. Yeah, thanks.
Hayley, you've posted a question in the chat. Did you want to?
Yeah, I can speak. I mean, it's really interesting. So thank you for fascinating discussion. I mean, it's interesting because I think you're saying that at the level of clinical services, it's already a challenge to introduce this holistic approach, or indeed to get a sort of joined up approach across services. But I was interested in what Lucy was reflecting, going back to how can one get the lens to go beyond the individual and to sort of, try and get away from, just some quite sort of moralizing judgments of women and their behaviors. And is it possible at a population and policy level to think about joining up across government departments intersectorally to try and really come up, address these really thorny, long-standing, kind of intractable problems that link back to structural determinants of health? And I wondered if there are sort of ongoing initiatives to do that, as Lucy was suggesting.
Lucy, your thoughts on that?
Well, I was just going to say, I'm not that I'm aware of in this area, but I'm not sure if Sue and Lydia, they might be able to correct me on that, being experts in this area. I think you made a really good point there in terms of the moralizing. I think that's quite a key point, that there are I can sort of reflect on this from a psychological point of view, that there are certain narratives that are quite widespread throughout society, the way people in general think about these things, and how we apportion blame when certain individuals experience certain outcomes, etc. And I think that can of course be a barrier to progress. But I think then that's a question for behavioural science teams like mine, where we have to understand, trying to understand, okay, if this is the way people are thinking, how can we work with that? How can we work to reframe? I think it, almost reflects on a point that Sue was making earlier as well, about, if we know that, if we know that people are, particularly wanting to tick boxes, or, they've got a certain way of thinking about things, sometimes it's about trying to identify what is that way of thinking and how can we work alongside that. That being said, I know that within OHID there is a Healthy Places team, and I know I haven't been working with them directly myself, but members of my team have been, and I'd be really interested to hear more about the work they do, because that is more thinking a bit more broadly about the kinds of environment people live in and what these kinds of place-based interventions can do. But of course, that is only one part of the puzzle. But I would imagine that they would probably be one of those teams who would start looking to try and bring together this kind of collaborative effort. That is just my speculation, of course.
I think theoretically, I think theoretically there probably is more opportunity since Public Health England is no longer with us, and we are now closer. Our team in a kind of health improvement space has moved into the Department of Health. The idea is that makes health improvement work as a cross government focus potentially easier. Certainly, we are closer to other government departments. So I certainly, that is that's the line, and I think that will be on us to really try to work to see how can we make the most of having better links in with DFE, with what's it called, the Office for Housing and Levelling Up, and all that is now closer to our fingertips. So I think it's a good challenge to us to, what more can we do, I guess.
I would absolutely agree with that, and I would also recognise, that we are constrained by our current political context in every sense of the word, and so the limitations of what we can do nationally. I think the important thing is to sort of try and model things nationally that we can then support local areas to model with, that have a little bit more distance from the other things that are going on at a national level, which obviously, particularly now, are quite constraining in terms of trying to push forward a new agenda on women's health, is going to be difficult in the current climate for lots of reasons. And so obviously there is a new women's health strategy coming, but also I think the government eye is on different priorities at the moment. And so I think that, I guess I would see as one of our main tasks is to implement and support local areas to implement with good evidence to back that up and support decision making at that level, while we strive to also try and broaden things across the wider government departments, because that is one of the, as Lydia mentioned, it is one of the widest principles of OHID. So we should be making those connections for sure.
Hayley, did you want to come back on anything that you've heard?
No, thank you. I mean, I think very thoughtful responses. I guess my concern, just from working in other contexts, is that quite often, particularly if resources are limited, then that certain models of care, for example, those oriented towards self-care, that might seem like improving holistic care, can actually potentially just reinforce ideas about individual responsibility and sort of in a way encourage a whole sort of attitude of blaming individuals. So I think sometimes one does have to sort of connect the sort of local, the clinical framing and the way care is framed to some of these wider issues. But I got a sense you appreciate that. Thank you.
Can I just come back on that, because I think that is such a key point. Whether you see self-care as empowering or whether you see it as actually denying access and putting responsibility, and I think we just need to review how because we talk, in a quite a throwaway way about self-care, and I absolutely think that's a key risk. And it's also excluding particularly of the already excluded population. So I think we do have to be very careful.
Yeah, I completely agree that it can reinforce inequalities, and it's a big concern.
Maya, did you want to come back in?
I know we are sort of ending soon, but I was just wondering if we have some colleagues who can throw perhaps some sort of comparative perspectives, and I was thinking particularly around the issue of gender equity generally within reproductive healthcare. And I know we have a colleague from Norway, Professor Bleistad, who's visiting CORTH this month. I've been particularly struck, I think, as we all are, about how these gender equity principles really sort of come into policy making. And I wonder if Astrid, you might be able to throw some light. Sorry to put you in the spot, but whether you might like to share some views.
I think it's very difficult to right now come in with something that has some substance here, Maya. But I've just enjoyed thoroughly these discussions and the presentations. But I can't come in with anything that would make give anything of a substantial contribution here. I'm sorry.
Thanks, Astrid. making that comment nonetheless, and Maya for throwing open that as an avenue for topic discussion. Colleagues, presenters, or audience participants, are there any sort of final questions or final thoughts? We've got just a few minutes left, but I'll just pause to see if anyone's willing to jump in and put their hand up.
Can I just say that I'll put my email in the chat, and if we're doing quite a bit of sort of evidence gathering at the moment, quite particularly around contraception right this second, but we're always really interested to kind of hear about new research that's going on that you think might be relevant in a policy space, and that you think we should be aware of. So really open for that, kind of really up for that line of communication, or whatever you say, to be there. So yeah, please do send through relevant things if you think that they would be on the basis of what we said today.
And I know Maya did participate in one of our pieces of work last year around inequalities, which was incredibly useful. So I think that CORTH has some really interesting thinking around framing and rights-based perspectives, which we're always interested to hear about and read about and try and integrate within all our approaches. So yeah, so anything that you think is useful to share, then it will be very, very welcome.
Great. Well, maybe as chair, I will pass over to Maya at the very end, maybe for a few of her closing comments. But just as chair, I'd just like to thank the speakers again, and also actually thank you for the audience, for those who came along and listened, and also for those who participated with questions. So I'll let Maya give the final few minutes of commentary, if you like. So would that be okay, Maya? Would you like to say a few closing words?
Absolutely, yes, I'd be happy to do that. And also, if my co-directors, who are here, Haley and Chi, I think, would you like to add something? And to the thanks, would you like to sort of please come in as well? And I mean, as ever, I think in CORTH we like to facilitate discussions and thinking about these issues, and what you've raised for us today has been, it actually fits in a lot with what we are trying to do. So I think Chi mentioned the adolescent menstrual health kind of work that she's leading on CORTH, and we are involved in. So we could be in touch about that. And then we are also in discussions at the moment on the issue of menopause with some of our members. So we would definitely like to sort of engage with you on that. And then we are also within our Narrating Blood a sort of network. We are working on anemia with some colleagues, and I know some of them were here from Ghana but have dropped out now, and Nigeria and India. So we just, we hope to discuss that with you as well, because it's just, I think, really important to get your views on what's happening here. And not just that, but also to maybe stand in solidarity when you are promoting these issues, whether it's at Parliament or with policymakers, etc. Then we are very happy to do that. So thank you very much for sharing, your really taking us to the heart of your thinking and making and your collaborate and your reaching out in a way. So thank you so much, and thank you to Keith and for chairing.
Thank you, everybody.